So a little bit about my experience being in STEM. So my pronouns are her and she, and I currently work in the School of Public Health here at Imperial. I'm a clinical academic fellow here, and I'm also a consultant in public health medicine. And I've had both positive and negative experiences in STEM. So I guess probably the reason I'm in STEM is because I'm gay, and I knew I was gay from an early age. So growing up in the late 80s, early 90s, you can probably guess my age, there was Section 28 was enforced. So you couldn't talk about it at school. There were very few role models in sort of TV and on radio, and so I felt quite ashamed. I knew it was, or felt that it was wrong, so I tried to overcompensate. I thought, oh, if I'm good at school, if I'm good at sport, maybe that'll make up for the fact that I'm gay, with family and friends. So when my grandmother said, oh, maybe you'd make a good doctor. Okay, so I did science A-levels and applied to medicine. When my mum said, oh, I'd really like you to go to Oxbridge, I was like, oh, God, okay, that might be quite tricky. So I worked really hard and went to Cambridge to study medicine. So in a sort of perverse way, it actually had a positive influence, and is why I'm here at Imperial today. And being a medic, I've worked in the NHS, I've also worked at Public Health England and a few other universities across London. And they've all had very good sort of anti-discrimination policies. But the real thing that's had the most impact for me, as someone perhaps who grew up with a bit of shame, so I've always been slightly underconfident of coming out at work, is this, the power of rainbow lanyard, its visibility. Because it's all been well having all these policies, which is what the NHS do, Public Health England, they're all public organisations that have great policies and benefits for the LGBTQ plus community, but it's visibility. So actually when I started here in October, and I had to have a slightly awkward conversation with my boss, because 4 weeks into the job, I had a 3-week holiday booked to Argentina. It wasn't a holiday, it was actually my honeymoon. So when I sort of walked in, and my boss was sat there with the rainbow lanyard, I thought, oh yes, I can be totally honest. I need 3 weeks off, I'm going on honeymoon with my wife to Argentina. So it makes a real difference, certainly for me, is visibility. And like the previous speaker said, the profiles, both for Imperial people, sort of plastered across the university, and also the events that are really promoted college-wide, like the LGBT History Month. So that's sort of my experience from a positive side. On the negative side, a lot of my research is in global health. And so I've worked in a lot of countries in Africa where homosexuality is illegal. And so often when I go to these countries, I say, oh, do you have a nice husband back at home? I'm like, yeah, well, sort of reassigning my wife's gender to male sometimes works, because I wear a wedding band. So it's difficult, it's complicated. And I think actually, in some respect, it's hindered, it's set me back in my academic career. Because in global health, to get really international recognition and sort of have credibility, you have to live and work in the countries that you're studying, you're doing sort of big field trials. So I've seen my peers sort of move their families over for 2 or 3 years, lead some really big clinical, really interesting, sort of important epidemiological trials, and I just haven't felt comfortable doing that, or living in these countries as a gay woman, openly with my wife. So now I've slightly sort of reshifted my focus to UK and sort of public health in Europe, and I mostly work on projects that require me just to go out for 2 or 3 months at a time. So that's a sort of negative way how it's impacted my career, or academic career, in global health research. So just something to think about. Okay, so this is the team I work with. So I'm in the Patient Experience Research Centre, and this is a fantastic group of people. We're very multidisciplinary. We have clinicians, public health researchers, medical epidemiologists, statisticians, and anthropologists. And our main aim is to improve the quality of health care, and also try and sort of bridge this gap between sort of bench to bedside. So to really try and improve or increase the impact of biomedical research for our populations. And we do this through advocating and supporting both public health and biomedical scientists here at Imperial to try and incorporate patient and public involvement within their research throughout the whole research cycle. So right from the start to sort of what research questions to ask, what research questions to prioritise, and also in terms of what studies design to use, right up to helping researchers to disseminate their research to sort of the wider community. And we also do our own research, and we're really sort of trying to build and generate the evidence base for the impact of public and patient engagement within biomedical and public health research. And the project that I've been involved with and have been for the last 2 years is this project called Adolescence 360. And I'm leading on the evaluation, the outcome evaluation of an adolescent sexual and reproductive health intervention, which has been designed or co-designed with adolescents within the communities. And this is in Nigeria, Ethiopia, and Tanzania. So I don't live in this country, those countries. I sort of go out and manage the sort of field studies and collect the data and analyse the data, produce the reports. And that's an example of how we use human-centred design or co-production, co-development with communities to basically try and develop interventions which will have an impact in real life. Because quite often now, and increasingly so, we're trying to align research with what actually will work in real life. Because we've spent a long time, especially in health, running randomised controlled trials in very sterile, controlled environments, and then you put them out into the real world and they don't work. And we're there scratching our heads, sometimes 10, 20 years later, wondering why the hell this hasn't worked. And it's because we've not really engaged with the community to ask these questions. So most of my talk, I'm going to talk about a case study, which is more from my sort of professional and practice side of things, where actually the science works, but we've not had an impact because we've not engaged with the community that we're there essentially to serve. So, you've probably all heard about Ebola. In 2013, 2016, there was one of the biggest outbreaks the world had ever seen in West Africa. And it predominantly affected 3 countries in West Africa: Sierra Leone, Liberia, and Guinea. And we saw up to over 28,000 cases. There's about 12,000 deaths. These are all thought to be gross underestimates, partly because surveillance in these countries is quite poor. And the Director General of the WHO at the time declared this a public health emergency of international concern. And the UK government, as a member state, was called upon for support. And so they deployed, or they asked for volunteers who worked in public health, medical clinicians, medical epidemiologists, to go out and help support the response. So I was seconded to WHO in Sierra Leone. So, a little bit about the sort of life cycle and the biology of the virus. It's a filovirus, and it was first recognised in 1976 in Zaire, now known as the Democratic Republic of Congo. And it's called Ebola after the Ebola River, which runs through northern Congo in Central Africa. Now, it's a zoonotic infection, so that means most of its natural life cycle is in animals, and it just sort of occasionally infects humans. And it's thought that transmission to humans, or the reservoir, is the fruit bat, from which then it infects humans directly, and then the infections can go from human to human, or possibly through a sort of intermediate host, so a non-primate, like a sort of chimpanzee. And in fact, in the West Africa outbreak, it was thought that the first case, which was actually a young boy, back in December 2013, it was thought that they were probably infected by either coming into contact with an infected fruit bat, or perhaps the excretions or secretions from the fruit bat. And then once he was infected, his whole family, the nurse that looked after him, it spread to the villages. And because there's a lot of there are quite porous borders between the three countries, which were all sort of interconnected, that it was then able to spread. And there was a bit of a slow response from the international community when they realised that this was a serious problem. So, to understand how we control or how we manage these outbreaks, we need to know a little bit about the epidemiology. So how is it transmitted? Well, it's transmitted through close and direct contact with infected bodily fluids, the most infectious being blood, feces, and vomit. And actually, for us, this is quite good news, which means it's not that infectious. So, in the sense, if in an audience, say, if someone here was in the early stages of Ebola, chances are none of you would get it, because you've really got to be showing signs and symptoms and be in very close proximity. So the type of people that get Ebola from an infected person are either people caring for someone who's sick, healthcare workers, or people involved in sort of burial or washing and managing the dead body. If someone in this room had flu, which is airborne, then probably quite a significant number of you would get it. Measles as well, very infectious. So actually Ebola isn't very infectious. However, it is deadly. So it has a very high mortality rate, and the symptoms are this severe hemorrhagic fever, which is common of these type of viruses. So you get fever, severe headaches, diarrhea, vomiting, and the sort of classic bleeding and bruising. Now, another important epidemiological characteristic is the incubation period. And along with the transmission, this is really important in terms of outbreak control, because it tells you how long you've got, essentially, from one person to be infected for them to be showing signs and symptoms. And because Ebola, unlike some infections, for example, measles can be infectious before people get rash, so that creates problems in terms of control. You are only infectious when you start showing signs and symptoms. So it's important to know that time period, because it also, in terms of control, I'll come back to that later. Currently, there are no specific drug treatments. There were some cases in this country that were treated with sort of quite experimental drugs. They're certainly not mainstream, still very experimental, still not 100% of work. And there are a few Ebola vaccine candidates now that are in clinical trials. And you may have heard that most recently there was a slightly smaller outbreak going on in the DRC, and they're using some of these still quite experimental vaccines to try and control that. So the mainstay is treatment, and the reason I still have a job is prevention. So that's really the sort of cornerstone of how you control an outbreak like Ebola. So, now we've talked a little bit about the transmission. How do you use that information, the sort of science behind, or the sort of epidemiology of the virus, to look at effective interventions? And there are lots of very strong evidence for interventions that work. Pretty simple, really, stuff. Public health isn't difficult, it just has to be done at scale. So the major routes of transmission in this outbreak were in a hospital setting through healthcare workers. And in fact, a lot of healthcare workers actually died during the outbreak. And the easiest way to stop transmission in the hospital is to do barrier nursing, provide good hospital design, make sure the patients are sort of quite far away from each other, and wear personal protective equipment that's then changed between patients. And this is a sort of very classic the yellow suit with the mask that was worn during that time for healthcare workers, once they knew what they were dealing with. The other thing is burials. And why is this important, specifically in West Africa? Because actually traditional burials and burial rites are a hugely important part of the community, and that sort of the sending off of a family member or a friend is really important. So there's about 20% of cases of Ebola were infected because of going to some sort of burial or funeral. And the reason for this is because part of traditional burials involves sort of the touching and the washing of the body. So essentially, with Ebola, you're most infectious right at the end when you die, so a dead body is extremely infectious, and you've got people washing and touching this body. And what were called superseder events were the funerals of very important people, traditional healers, community leaders, because those funerals are attended by a lot of people, thousands of people, all of them wanting to touch the body, show their respect. So a real problem in terms of spreading infection. And like I said, it was a real transmission route. So again, easy, or you take the body, you wrap it up, you protect it. The people who deal with it dress them up in suits, and then bury them sort of fairly far away in quite a deep sort of burial ground. And in fact, in Sierra Leone there were these specific Ebola burial grounds, so fairly easy intervention. And then the thing that I was most involved with, or helped coordinate, was people in the community. So what you want to try and do with active case finding and contact tracing, which is what I was involved with, is reduce the amount of time a sick person is sort of mixing with other people. You want to try and isolate, quarantine sick people as soon as possible so that they then can't pass on the infection. Again, fairly simple. And this is an example of a poster where we were asking the community if they had symptoms to call us. We would send an ambulance and then take them to the hospital for diagnosis and then treat if they were found to have Ebola. There was a questionnaire that helped our surveillance officers, which by that point, because all the medical staff were in the treatment centres, we were actually getting medical students, local medical students, to go around and sort of do the sort of risk assessment and the case finding. And this, again, evidence-based, simple strategy on what you do in an Ebola outbreak. So it's the case identification. So we went out every day into the community, asked people, is there anyone in the village with a fever? Is there anyone being vomited? If the answer is yes, we go and assess that person. If there's a suspicion it could be Ebola, they're then taken by ambulance with people with PPE to the nearest isolation unit. They're tested and then kept in for treatment if that's the case. If not, they're allowed back into their community. If they're positive, then that opens up a whole other can of worms, because you then have to risk assess everybody that might have been in contact with them while they've been unwell. And then once you've found them, you've got to tell them that they've got to be in quarantine or in isolation for 21 days, because that's the 21 days where they might be incubating the disease. So we would get contact tracers to go in every day to take the temperature of some close family members or people that we thought were at risk. And that's a very kind of simple strategy. But, so, 3 routes of transmission, 3 simple strategies, but why did it take 3 years to get this outbreak under control? Well, because we didn't listen. We weren't listening to the community. And when we started listening, this is what we found. So people were burning ambulances, attacking healthcare workers, they were hiding their sick, people were running away when they were in quarantine, because no one thought to think that if you put someone under essentially house arrest for 21 days, they're going to lose their job, so how are they going to feed their family? So all of these sort of social things, that as scientists, as epidemiologists, we've got the tools, we've got the strategies to solve this problem, but why isn't it working? And a strategy that probably would be so easy and simple to implement, perhaps in a country like the UK, and we do it all the time for things like measles or outbreaks of TB, just was not working. And these are some of the things that we were hearing. Some fear, rumours that got out of hand, disrespect. So, taking dead bodies away without giving them a proper burial was a massive issue, huge. So real problems. So after people started to listen, the WHO employed fewer clinicians, fewer scientists, fewer medical epidemiologists, and brought in the social scientists, the anthropologists, the social mobilizers, to find out what was going on and how we could change what we were doing so that it would work, so the science would work in this context. And this is an example of some of the things that we found and some of the things that we have done as a result of that sort of social mobilization movement that now is written into every outbreak control plan for Ebola and for other viral hemorrhagic fever. This pillar that we call social mobilization, which is now a key part of any outbreak control strategy. So in terms of tailoring messaging, so when we were there, we saw a group of local healthcare workers go in to a community with an ambulance and let people go in the ambulance, touch the ambulance, just kind of demonstrate that it wasn't a sort of time machine, that it was fine and it was going to take them. One of the things I noticed was that just sort of basic things. Family members weren't being called to say what hospital their relative had gone to or when their relative died. So they saw the ambulance come and then didn't know where they'd gone. So I don't blame them for thinking that probably they'd be sort of taken away and their organs harvested. So simple things by just, when someone arrives at the hospital, calling or letting the family know where they are, just basic things that were introduced. And then this active participation in the response. People wanted to feel involved, people wanted to take ownership of the response. And so getting people to do, training people up, people as part of the community, to be contact tracers, to do the active surveillance work, was also key to sort of bringing the outbreak eventually to a close. So I hope I've convinced you that involving the patients and the public is really important for research, because if you don't think about these things, and you don't take people's views and involve people early on, you're going to create a medical product, an intervention, that then when you put it into the real world, just don't work. And I imagine, like myself, all of you, the reason you're in science, the reason you're in STEM, is to want to make a difference to sort of the world and the people around you. And doing PPI is one way of doing that. So if you want to get in touch and you're interested in doing more patient-public involvement, I have to say now, certainly in medical research, it's becoming mandatory. There's a big section in all grant applications now. How have you involved? How have you done PPI? And for a lot of people, it's a tick box exercise, but I hope I've kind of given you some evidence today to suggest that actually it's really quite important. Thank you.